a few questions which have been a little gray in that the question papers. And selected 3 topics for discussion today. There are some more to follow in the ensuing weeks. And let us see what Dr. Kayal has got to say about it.
Yes, sir. Good evening, sir. Introduction about this topic. The fetal circulation supplies fetal tissues with oxygen and nutrition from placenta. It bypasses fetal lungs. The presence of fetal hemoglobin ensures the oxygen delivery is maintained despite low oxygen partial pressures. At circulation of fetal blood through placenta ceases, acute changes in pulmonary and systemic vascular resistance occurs and the lung begins to function. Subsequently, the foramen ovale, ductus arteriosus, umbilical vessels close to transform into a corresponding ligaments. Neonates may revert to persistent fetal circulation and decreased pulmonary blood flow and right to left shunt in response to certain stimuli such as hypoxia, hypercarbia, acidosis, and cold. So the circulation in the fetus, deoxygenated blood is conducted to the placenta via 2 umbilical arteries. Umbilical arteries are arise from internal iliac arteries. Gas exchange occurs in placenta. Oxygenated blood from placenta passes through single umbilical vein and enters IVC. About 50% of the blood in the IVC passes through liver and the rest bypasses liver via ductus venosus. IVC also drains blood remaining from the lower trunk and extremities. On reaching the heart, blood is effectively divided into 2 streams by the edge of interatrial septum, which is known as crista dividens. A large stream is shunted to the left atrium through foramen ovale, which is lying between the IVC and the left atrium. The other stream passes into the right atrium, where it is joined by the blood from SVC. This stream has low partial pressure of oxygen. Because of large pulmonary vascular resistance and the presence of ductus arteriosus, most of the right ventricular output passes into the aorta at a point distal to the origin of the arteries to the head and upper extremities. The diameter of ductus arteriosus is similar to descending aorta. The patency of ductus arteriosus is maintained by low oxygen tension and vasodilating effect of PGE2. Blood which is flowing through the foramen ovale into the left atrium passes into the left ventricle, where it is ejected into the ascending aorta. The partial pressure PO2 in kilopascals of umbilical vein, it is 4. Umbilical artery, it is 2. In the maternal arterial blood, it is 13. The PCO2 of umbilical vein, it is 6. Umbilical artery, it is 7. And the maternal arterial blood, it is 4. The percentage of hemoglobin saturation in umbilical vein, it is 30. Umbilical artery, it is 70. And maternal arterial blood, it is 100. About fetal versus adult hemoglobin, this has high hemoglobin F percentage, which is 75%. HbF has lower affinity towards 2,3 bpg. So ODC curve for hemoglobin F is shifted towards left when compared with adult hemoglobin. So this favors oxygen uptake in the placenta. That is, the P50 value is 2.4 kilopascals for fetal blood and 3.5 kilopascals for adult blood. So the changes which occurs at birth, several cardiopulmonary adaptation occurs which results in gas exchange being transferred from placenta to the lungs. Umbilical vessels are obliterated when the cord is clamped externally. There is therefore fall in blood which flows through the IVC and ductus venosus. Later, subsequently, it closes passively over the next 3 to 10 days. A dramatic fall in the pulmonary vascular resistance occurs with the lung expansion. A reduction in hypoxic pulmonary vascular vasoconstriction and a stimulation of pulmonary stretch receptors contributes to this process. The increase in pulmonary blood flow leads to a loss rise in pulmonary venous return towards left atrium. The left atrial pressure therefore exceeds right atrial pressure. This reversal pressure gradient across the atrium allows the flap of the foramen ovale to push against the atrial septum and the atrial shunt is effectively closed. Although the initial closure of foramen ovale occurs within minutes to hours of birth, anatomical closure by tissue proliferation takes several days. As a result, all bloods from right atrium now passes into right ventricle. Ductus arteriosus constricts due to increased partial pressure of oxygen This process usually completes within 2 days after birth. Other changes over several weeks includes reduction in the thickness in the walls of the right ventricle and the muscle layer of the pulmonary arterioles, and increase in left ventricular wall. Then about persistent fetal circulation, under certain circumstances, the newborn may revert back to fetal type circulation, which is termed as persistent fetal circulation. In certain stimuli, pulmonary arterioles constrict and to an increase in pulmonary vascularisis. The stimuli includes hypoxia, hypercarbia, acidosis, cold. Increased pulmonary vascular resistance favors right to left shunt, and fossa ovalis, foramen ovale, and ductus arteriosus subsequently remain patterned. Thank you, sir.
Okay. This question was asked in the last theory exam.
Yes.
And we have described the fetal circulation, and the points that you have mentioned are very, very valid and useful. That overall oxygen percentage in fetal blood is compared to the maternal blood is very low.
Yes, sir.
And the partial pressure of carbon dioxide in the fetus is slightly higher compared to the maternal. So what is the adjustment that nature has made in the mother for removal of carbon dioxide? What is the ABG value of the pregnant woman will be? Are you there, Dr. Kayal?
Yes, sir. Yes, sir.
What is the respiratory rate of a pregnant woman?
It is increased.
Increase. So what will happen to the carbon dioxide?
It will eliminate the carbon dioxide.
Eliminated. So what is the condition called? Increase the respiratory rate, washing out the carbon dioxide. What is the name of that condition?
Respiratory drive.
Respiratory alkalosis.
Yes, sir.
Ah.
Yes, sir.
So this is a nature's beautiful adaptation to remove the carbon dioxide from the fetus. Okay? So maternal blood which goes and perfuses the placenta and enters the fetal circulation has comparatively low carbon dioxide, so that the carbon dioxide produced by the metabolism of energy substrates in the fetus are removed. Okay? And the normal oxygen partial pressure is able to observe the oxygen demand, because the lung is not working in the intrauterine period in the fetus. Maternal circulation only has to deliver the oxygen that is required. So the basic important difference between the mother and the fetus is the overall oxygen concentration in the fetus is never 100% like the mother. So there is always a partial pressure difference which is able to deliver the oxygen. And the fetal carbon dioxide level is slightly higher, and maternal carbon dioxide is always slightly lower because of the adaptation that the mother has by increasing her respiratory rate and washing out the carbon dioxide with a mild respiratory alkalosis. This point is important for all of us as anesthesiologists, because majority of the time when there is a need for an operative delivery, we administer spinal anesthesia and the mother continues to have her normal respiratory pattern. But in cases where you have to give general anesthesia for cesarean, which is very uncommon nowadays, but if it happens, then whenever you try to control the ventilation of the mother, do not hyperventilate too much, number one, or slightly maintain the same alkalosis in the mother till the fetus is delivered, so that the fetus will not have CO2 accumulation. Any suppression of respiration in the mother and accumulation of CO2 in the mother with a raised PtCO2 value will make the baby be born in a state of carbon dioxide accumulation. So the CO2 narcosis will happen in the fetus and it will affect the ABGAS score. So When, if at all you have to give GA, you have to maintain the same mild respiratory alkalosis by slightly increasing the respiratory rate when you are controlling the ventilation or assisting the ventilation, so that till the time of birth, the fetus will have sufficient CO2 elimination because of the partial pressure difference. This is number one. And you said the fetal circulation will change to neonatal circulation, which is like almost like an adult circulation, where the lungs start functioning and the blood starts flowing into the pulmonary circulation, because intrauterine life, the pulmonary pressures are, the vascular pressures are very, very high. That is one of the reasons why the blood will not flow into the pulmonary artery up to the distal circulation. And how is that blood, which has to, a small portion of blood which goes into the pulmonary artery, how does it come and join the systemic perfusion?
So ductus arteriosus.
Ductus arteriosus communication is there. Okay, so even the small amount of blood, before it can reach the terminal parts of the pulmonary circulation, it is diverted to the aorta through the pulmonary ductus arteriosus communication. And as you rightly said, there are three communications. One is the ductus venosus at the liver level. Second is the foramen ovale at the intraatrial level. And third is the pulmonary artery to aorta communication, which is the ductus arteriosus. So once the baby is born and takes its first breath and expands the lungs, and the oxygen is available at the alveolar level, the pulmonary circulation, which was a high resistant tight circulation, gets relaxed and becomes a very low pressure circulation. And on contrary, the systemic circulation, which was a very low pressure circulation, increases this pressure, and SVR increases and systemic vascular pressure increases. And the shunting between the right side and left side is totally stopped because of the rise in the left atrial pressure, closing the foramen ovale and preventing any right to left shunt, which will prevent the deoxygenated blood mixing with the oxygenated blood. So these are the changes that are happening. And in neonatal anesthesia, why they have asked this question in the exam is, whenever you handle a neonatal patient, what is a neonate? Till what time after birth a child or a baby is called neonate?
Till 28 days.
First 28 days, very good. So the neonatal period, what are the common emergencies you can encounter? There you have to immediately do the surgery, otherwise the life of the neonate will be in danger. Can you mention a few surgical conditions where you have to operate in the neonatal period itself? Have you heard of tracheoesophageal fistula? Have you heard of congenital diaphragmatic hernia? Have you heard of ampulocele, gastroschisis? Okay, so many conditions are there which require immediate surgery in the neonatal period itself. So in such conditions, even though the child has reverted to the adult-like circulation, which is called neonatal circulation, immediately after birth, once they start their regular respiratory activity, can the circulation revert to the fetal type? That is a communication between the right side and left side existing with the foramen ovale being still open, ductus arteriosus flow instead of left to right being right to left. And that all happen.
So we
Any
can
other
maintain that.
post-DA? I think there are two post-DA primary candidates here. One is, I think, Dr. Damodaran and Dr. Kamal Pandian. Are you there, doctors?
Hi,
Yes,
sir.
Can the circulation revert from the adult type to the fetal type intraoperatively? And if it reverts, what will happen? See, imagine now
failure,
the
sir.
what?
Heart,
Anybody answering?
no idea, sir. Maybe heart failure, sir.
First will be extreme hypoxemia. Okay.
Extreme hypoxia. Okay,
Because
sir.
now once the adult circulation is established by the lung getting expanded by the respiratory activity of the newborn, right and left sides are completely separated, and the circulation becomes a in continuous circulation from right side to right atrium to ventricle to the pulmonary, getting oxygenated, going to the left atrium, left ventricle, going into the systemic circulation, and then delivering the oxygen to the tissues, coming back to the right atrium. Okay, so from parallel, it becomes a serial circulation. Whereas, if it reverts back to the fetal circulation, what will happen? The deoxygenated blood will mix like with the oxygenated blood. It will be just like a situation where you have a tetralogy of Fallot. There are a large amount of right-sided blood mixing with the left-sided blood. And child will go in for severe deoxygenation or hypoxemia. And that may produce all the problems. So is there any name for switching from the adult to the fetal circulation? And once you correct the basic mistakes that have happened, to revert back from fetal to adult, if it goes on happening during the intraoperative time several times, is there any terminology used for that? Switching from adult to fetal, fetal to adult, again adult to fetal, again fetal to adult. If it happens several times intraoperatively, is there any particular name for that condition? That is called the flip-flop circulation. Okay? Flip-flop.
Okay,
So,
sir.
switching from adult to fetal, fetal to adult, is called flip-flop circulation. And changing from the fetal circulation, the intrauterine life, to the immediate neonatal circulation, which is similar to the adult circulation, that is called the transitional circulation. Okay, that is the term that has been asked in the question. What is the definition of transitional circulation, and what are the changes that happen, and what factors contribute to that? So I'll just share my screen with you to make you understand that book better.